Good afternoon, everyone. Welcoming one and all to this session on Duane retraction syndrome. We have called it the DRS panorama. Let us see how much we imbibe from it. Our first speaker is Dr. Mallika Harikrishnan. Madam will be dealing with an overview of CCDDs.
Good afternoon, one and all. CCDDS, clinical congenital cranial degeneration disorders. It sounds a complex terminology, but actually it is not. In the next few minutes, I will try to make it as simple as possible. The brainstem innervates the orbit. We all know that. Orbit is very convoluted space. There are a lot of things in a small space. The brainstem has to form. The nuclei have to form. They have to send axons, exit the brainstem, cross the space, then go to the specific target. It's a very complicated process innervating the orbit. It is amazing that all things will happen so smoothly. But if something goes wrong, there is this innervation process. We call it as CCDDS. It may be a subnormal innervation or an aberrant innervation. So it is a unifying concept of incompetent strabismus involving third, fourth, and sixth cranial nerves, as far as we ophthalmologists are concerned. It can involve either oculomotor nerve, abducens nerve, or a trochlear nerve. The conditions affecting abducens nerve are the Duane's retraction syndrome, Mobius syndrome, and horizontal gaze palsy and progressive scoliosis. That affecting the oculomotor nerve are congenital fibrosis of extraocular muscles, congenital ptosis, some variety, the Marcus Gunn jaw winging phenomenon, and then monocular deficit syndromes, some varieties. And those affecting the trochlear nerve are congenital superior oblique palsy and the Brown syndrome. Fibrotic muscles and floppy tendons are seen in many of these conditions. Happens secondarily. The major defect will be either nuclear or the subnuclear level. So I would like to classify the CCDD mechanism into three: supranuclear, nuclear, and infranuclear. In the supra or internuclear problem, the problem is with the axon crossing. So if you take the MRI, the nucleus will be normal. In the nuclear formation, this is due to transcription factor deficiency. Here it will be an abnormal nucleus. In the infranuclear problem, it can be due to axon guidance, axon transport, or synapse formation. The nucleus has to be theoretically normal, but there can be secondary degeneration of the nucleus because of the retrograde degeneration. So I will take you to along some of the common causes, some of the conditions. The one and only example for supra or internuclear problem is the horizontal gaze palsy and the progressive scoliosis. It is due to ROBO3 mutation. ROBO3 is nothing but an axon guidance receptor which is responsible for crossing of pathways in the hindbrain. So this is a differential diagnosis for bilateral types of type 3 DRS. Under the nuclear conditions, mutation in the transcription factor gene is the problem. The DRS phenotypes HOX7, SAL4, MAFB are examples. The congenital fibrosis of extraocular muscles, FOX2A mutation, and the Mobius syndrome. Mind you, most of these are idiopathic, the Mobius syndromes. And SAL4 DRS is an example. SAL4 is the transcription factor responsible for sixth nerve and digits. So in a child with SAL4 DRS, There can be DRS, unilateral or bilateral, usually unilateral. There can be digital agenesis, renal agenesis, and a peculiar syndrome called radial ray syndrome, where there is shortened radius and abnormal angulation between the thumb and the fingers. In MAFB-DRS, there can be bilateral DRS and deafness. This constitutes 1% of the DRS cases and is said to be the most common gene mutation causing DRS. Suppose you see a family of DRS where there is bilateral DRS and autism and deafness. You can think of this HOX7 mutation. This lady is having ptosis, ophthalmoplegia, pupillary abnormalities. Her eye is fixed in horizontal gaze. This is FOX2A mutation. This is a transcription factor exclusively for the third and fourth cranial nerve nuclei. And this is the only CCDDS where you can get retinal dysfunction as well. This is a child with esotropia, bilateral facial palsy, and bilateral sixth nerve palsy, Mobius syndrome. And coming to infranuclear problem, as I said earlier, it is due to axon or synapse problem. The DRS phenotype, CHN1 mutation, and CFUM1 and 3 due to KIF21A and TAP3 mutation are examples. In CHN1 DRS, most of the patients are indistinguishable from the sporadic DRS. Overall, they can have higher incidence of bilateral or vertical abnormalities. This is CFUM1 due to KIF21A mutation. KIF21A is the gene responsible for transportation of substances along the axon. You can see the axon and the KIF21A. And in the TAP3 related CFUM, this is a boy with congenital fibrosis of extraocular muscles. TAP3 is the gene for microtubules on which the KIF21 can ride over. So if in KIF21, if it is deficient, the KIF21A cannot walk on the microtubules. Coming to the Duane's retraction syndrome, because this is the most common variety of CCDD we encounter. We know it's a constellation of clinical features like the partial deficiency of adduction, oblique movements with attempted adduction, complete or partial absence of abduction, retraction of globe on adduction, narrowing of palpebral fissure on adduction, upshoot or downshoot of the globe with attempted adduction, reduced convergence. Does it have some other names? Yes. Stilling-Turk-Duane syndrome. It was Jacob Stilling in Germany in 1887 who described this condition first, followed by Sigmund Turk. But it is known as Alexander Duane of USA because he published a case series of 54 cases in 1905. 1 in 1,000 to 1 in 10,000 in general population are this is the incidence, and 1 to 5% of all subsistence cases are DRS. It may be an isolated unilateral finding or in conjunction with other congenital anomalies. Females are more commonly affected because the susceptible genes are sex-linked or there may be higher estrogen levels during embryogenesis. Left eye is more commonly affected than right eye, especially in type 1, type 3. What are the etiological factors? First, they propose the mechanical anomalies. Turk said that it is due to abnormally tight lateral rectus, which behaves like an inelastic band. Wool said he noted a congenital anomaly. Could it be due to some related to birth trauma or some nuclear aplasia was some other people? And some other people suggested that it's due to dual insertion of the medial rectus, one in the usual place and the other posteriorly. Could it be due to innervational anomalies? Brain in 1956 studied the electrical potential generated by the muscles in various cases in DRS. He found that no lateral rectus potentials in abduction and maximum lateral rectus potential in adduction. There are some electromyographic studies which came. All studies found medial rectus innervation normal. Strachan and Brown quantified this paradoxical innervation. They said that synergistic innervation between medial rectus and verticals and obliques. Finally came the CNS abnormality theory. Sixth nerve innervation to lateral rectus was defective. That is they found. It may be due to nuclear, maybe an abnormal innervation by the oculomotor nerve or an absent or hypoplastic abducent nucleus. Maybe an infranuclear problem in the cavernous sinus. Supporting neurological theory are presence of synkinesis along with the DRS and the abducting nystagmus in the normal eye. So finally it came. This is the very phenomenal paper which came that it is due to absence of abducent nerve in the Duane syndrome, which is verified by the magnetic resonance imaging. This was published in the American Journal of Ophthalmology. And thereafter many studies came, which was one from the RP Center. It was published in Indian Journal of Ophthalmology. So with all these, it is depicting that the DRS could be classified under CCDDS. Genetics, 90% are sporadic, 10% are familiar, autosomal dominant, and twin studies have said that there is a mirroring is there. If one child is having DRS in one eye, the other twin will be having DRS in the other eye. So to conclude, CCDDS are a group of disorders that result from disinnervation of the ocular and facial musculature, which arise from the abnormal development of individual or multiple cranial nuclei or their axonal connections, majority with a proven or suspected genetic etiology. Some will have additional consistent systemic malformations. DRS is the most common of the CCDDS, and many of the ocular CCDDS come as DD for DRS. If the pathogenic variant in the family is known, molecular genetic testing can be used to clarify the genetic status of at-risk relatives. Thank you.
Thank you, Mallika Madam, for that. Now we hand over the session to Dr. Divya Kishan to address the practice essentials whenever a DRS patient comes along.
So good evening, everybody. First of all, let me thank Dr. Samyukta for giving me this opportunity to speak on this topic, Duane's retraction syndrome and the practice essential. Now, as already discussed, it falls in the broad category of congenital cranial disinnervation disorders, which include abnormalities of the innervation of the ocular and the facial muscle. It includes the congenital fibrosis of extraocular muscle, the Mobius syndrome, congenital facial palsy, to name a few. So it basically has varying disorders in the horizontal movements with the characteristic finding of retraction and narrowing of the palpebral fissure, with or without upshoots and downshoots. And it is named after Dr. Duane, who had actually put in Alexander Duane, who had put in a case series of 54 cases of Duane's for the first time. The etiopathogenesis includes mechanical, innervation, neurological, and genetic factors. I would be discussing about the classification of Duane's retraction syndrome. Actually, it is practically not easy to classify it into compartments because Duane's is basically a spectrum with alignment varying from ESO to ortho to exo, upshoots and downshoots from mild, moderate to severe, and abduction and adductions restrictions from -4 to full, and the field of binocular single vision from narrow to wide. The most popular classification that we see along is that of the Huber, which is based on the electromyographical findings. This is the type 1 Duane's retraction syndrome, and as you can see here in the right eye, the patient has defective abduction, and on attempted adduction there is narrowing of the palpebral fissure and retraction of the globe. So what causes Huber type 1? So as we know, it is the third nerve that supplies the medial rectus and the sixth nerve the lateral rectus. But in this particular condition, the third nerve gives aberrant branches to the lateral rectus. So adduction is normal because of the third nerve, but on abduction, there is co-contraction of the medial rectus, which causes abduction restriction. This is a type 2 DRS. In type 2 DRS, what you see is the adduction is more affected than abduction. That is because the third nerve fibers, more of it supplies the lateral rectus, and the sixth nerve innervation is also decreased. In type 3 DRS, as we can see, the third nerve completely supplies the lateral rectus and there is no innervation to the medial rectus. So both adduction and abduction are restricted in this particular case, and adduction causes narrowing and retraction of the palpebral fissure. There are also other systems of classification like the PAP system, which is based on abnormal co-contraction, the Malbarn, which is based on the motility changes, Lyle and Bridgman, that also based on the motility changes, and Huber that we have already discussed. But the one that is practically more important is the classification that is based on the primary position deviation into the ESO, EXO, and ortho DRS. Now, upshoots and downshoots are a characteristic finding that you see in case of Duane's, and that is because the co-contraction causes slippage of the globe, and that pulls the eyeball downwards. There's a grading for the upshoots is done with the involved eye in maximum adducted position. A straight line parallel to the intermediate canthal line is drawn from the pupillary center of the fellow eye, and based on where it is bisecting in the affected eye, you can grade it as 1, 2, 3, 4. When it is between the center of the pupil and pupillary margin, it is grade 1. If it is at the pupillary margin, it is 2. Then anywhere between the pupillary margin and the limbus, it is 3, and outside it becomes grade 4. Now the retraction grading is also likewise. With the involved eye in maximum adducted position, a scale is used at the center of the palpebral fissure width to measure the palpebral fissure height, and that is compared with that of the fellow eye in abduction. If there is no difference between the two and there's no narrowing, if the size is less than 25% difference, then it is grade 1. If 25 to 50% is grade 2, 50 to 75% is grade 3, and more than 75% is grade 4. It is important to look for any systemic other associations in Duane's. 10% of familiar autosomal dominant with CHN1 gene involvement. Now, isolated DRS without systemic anomalies, DURS1 locus on 2q31 is involved. The various syndromes that may be seen in patients with Duane's includes the Okihara syndrome, which is also known as the Duane's radial ray syndrome, and that has got the malformed or absent thumb and absence of radius, and hearing deficit, heart and kidney defects associated. The Holt-Oram syndrome is also known as atriodigital syndrome. It has got cardiac limb syndrome with anomalies in the cardiac and bones in the arms and the hand. The Bosley-Sally-Alloranay syndrome is another condition with bilateral DRS and inner ear malformations, cerebrovascular and cognitive abnormalities. There are cases of sporadic DRS, and that is associated with other congenital malformations of that of the skeletal, auricular, ocular, and neural. And that is because there is a critical period of embryogenesis, that is during the 4th to 8th week of gestation, and any insult, like in cases of thalidomide embryopathy, can cause various congenital malformations, including the DRS. The other common syndromes that may be seen include the Goldenhar syndrome, the Klippel-Feil syndrome, where there is a fusion of the cervical vertebrae, there is a Wilder-Rank syndrome, Noonan syndrome with unusual facial features, congenital heart problems, bleeding problems, ocular cutaneous albinism, and arthrogryposis multiplex congenita. It is not only these systemic conditions, but ocular manifestations and malformations can also be associated with Duane's. That can include the dysplasia of the iris, trauma, pupillary anomalies, cataracts, colobomas, epidermal dermoids, and optic nerve hypoplasia. In some cases, you also find that there are disinnervation disorders associated with it, like the crocodile tear syndrome, where there are accessory branches from the gustatory nerve erroneously end in the lacrimal gland and cause problems. And in Marcus 1, which is a more common one, you find that the fibers, muscles of mastication are erroneously elevated the levator. Although we say that retraction of the globe is a characteristic finding in Duane's, there can be some conditions which can mimic Duane's that can present with acquired retraction syndrome, and that include trauma and orbital wall fracture. There could be bony orbital metastasis, orbital inflammation, orbital surgery, thyroid myopathy, conjunctival surgery causing scarring, head injury, intracranial injury, and brainstem tumors such as glioma and skull base meningioma. So they can fall in the category of inverse Duane. We call it as inverse Duane because we always see that in Duane syndrome, the retraction on palpebral fissure usually occurs in adduction, whereas in these acquired conditions, the retraction occurs during abduction, and that is mostly associated with medial rectus abnormality, innervational misdirection, and secondary to restriction from trauma or surgery. And of these, the category of pseudo-Duanes mainly include those involving the medial rectus due to acquired or congenital factors that affect the medial rectus. Like, for example, if there is a trauma with medial rectus entrapment in the medial orbital wall, that can also cause retraction when you try to abduct. Now, the other differential diagnosis that you need to differentiate from DRS could involve an infantile esotropia where the eye is in adduction and there is an abduction restriction. But the characteristic finding is that even if there is cross-fixation in infantile esotropia, when you occlude one eye and try a doll's eye maneuver, the abduction becomes full. Another one is a lateral rectus palsy. And in lateral rectus palsy, the characteristic finding would be that when you see the primary position deviation will really correlate with the abduction restriction. Because sometimes in a Duane's, you can see an ortho Duane with -4 restriction of abduction, but that does not happen in a lateral rectus palsy. Also, the characteristic findings of retraction and upshoots will be lacking in case of the lateral rectus palsy. So, the take-home message is that even though retraction is a very characteristic finding that you see in Duane syndrome, we need to watch out for acquired conditions which can present as retraction because the management totally varies. And also we need to look out for the systemic associations as well as the coexistent ocular manifestations. Thank you for the patient listening. Thank you.
Next, I like to invite Dr. Samyukta. She is assistant professor in Government Medical College, Thrissur, and our in the hospital alumnus. She will be speaking on varied presentations and examination sequence.
Good afternoon, everyone. Sir Arthur Jampolsky has rightly stated that the diagnosis of DRS is established by the examiner being aware of and recognizing the various patterns. So we move ahead with our topic, the varied presentations and clinical examination sequence. So these are the reasons why DRS patients seek an ophthalmologist's attention. The possible presentations are limitation of ocular movements, noticeable ocular deviation, altered head posture, or cosmetically unacceptable vertical movements. So, apart from the routine points which you will attend to in a history-taking protocol of squint, give more stress to the onset of deviation. Most of the times this is a congenital anomaly, but which presents very late to the clinician. And give due stress to the presence or absence of diplopia and its onset, and give importance to the presence and onset of anomalous head posture, probe whether it is present at all times of the day, whether it is present for distance or near, and look into associated hearing deficits and neurological issues as well. Now, these are the different presentations. We might not have seen all these types in a routine clinical practice. It can be a unilateral DRS or a bilateral DRS. The classic is the ESO-DRS. ESO-DRS with anomalous and normal LR activity. ESO-DRS with overshoots in opposite gaze, relatively immobile globe, simultaneous abduction with no retraction, fixation with the DRS eye with overshoots in the opposite eye, Y pattern, lambda pattern, subnormal LR without anomalous LR. Now, bilateral patterns are seen in 15% to 20% of DRS cases. They can have fusion, may not have fusion also. Rare varieties include vertical DRS and synergistic divergence as well. Now, this is a case of synergistic divergence where you see large exotropia with gross adduction deficit, and as soon as the patient is attempting adduction, there is a simultaneous abduction. And this is vertical retraction syndrome. Here there is a horizontal DRS with globe retraction in vertical gaze positions. And there may be associated limitation of vertical eye movements. Here this patient has a limitation in infraduction. And this is bilateral ESO-DRS without fusion. So as you proceed with your clinical examination, inspect for these different things. Divya has already mentioned the coexisting anomalies, and give due importance to multidisciplinary referrals whenever you suspect a systemic association. So you proceed with your visual acuity estimation with age-appropriate methods of vision assessment. Hypermetropia, hypermetropic astigmatism constitutes the most common refractive anomaly. Accommodative element has to be ruled out by a cycloplegic refraction. You can reserve it to the end of your examination. Amblyopia, the major causes are anisometropic amblyopia and ametropic amblyopia. Strabismic amblyopia is seen in 25% of bilateral DRS. So you're starting your motor examination aspect, measure your head posture in degrees, document it well. It is important preoperatively to assess your results postoperatively. So we know this is to maintain binocular single vision and to make up for the duction deficit. Fatima madam has demonstrated her own innovative mechanism, cost-effective mechanism to measure the head postures. Document the ocular posture, presence of nystagmus, ptosis, pseudotosis, facial asymmetry, if any. Now, ocular rotations, this is the cornerstone in diagnosing and differentiating DRS from similar clinical entities. Do it in neutral head posture, and a thoroughly done ocular motility examination will help to pick associated motility disorders, incomitants, alphabetic patterns, etc. Versions to be checked first, followed by ductions, all the deficits to be noted here. And you can on the spot take an iron gaze image to have a reference to later on. Now, all these anomalous vertical movements, overshoots, globe retraction, narrowing and widening of palpebral fissure, all these things become evident at the end of your ocular motility pattern examination. Now, these are the notable features. Abduction deficit, which is disproportionate to the primary position deviation. And the underlying adduction deficit becomes evidenced by remote NPC. Another interesting feature is that an ESO-DRS may have an exotropia in the opposite gaze due to the underlying adduction deficit. So this is your screening Hirschberg test. The deviation can be an ortho-DRS, exo-DRS, or ESO-DRS. Esotropia is the most common primary position deviation. Cover tests follow to be done in habitual head position and also in the forced straight ahead primary position. Abducting saccade of the DRS eye will be poor during the cover test. You quantify the deviations by doing prolonged prism alternate cover tests to be done with the prism in front of either eye separately. So this will give you the primary and secondary deviations. Upshoots and downshoots are seen in nearly 43% of cases. So if you do your examination correctly, you will get to know whether it is a mechanical overshoot or an innervational overshoot. So mechanical overshoot occurs abruptly, whereas in innervational, it is a gradual movement. Mechanical overshoot is it is peculiar in that the upshoot and downshoot can occur simultaneously in the same patient, whereas in innervational, either of these would be present. Both cannot simultaneously be seen. Vertical deviation in primary position is not seen if it is of mechanical etiology, whereas in innervational overshoot, there would be a typical large vertical deviation in primary position. So these have already been told about. Grading of overshoots, grading of globe retraction. And the patterns, V pattern is the most common type which we see in DRS. In bilateral DRS, they tend to have A pattern more frequently. Now this is an image of a lambda pattern DRS. Sensory examination follows, Wirth 4 dot test, stereopsis test. Now coming to the most important thing when you plan your surgical correction of DRS, do have a very good idea about FDT, active FGT, and force degeneration test. So we know in routine FDT, the patient is instructed to look as far as possible into the field of action of the muscle being tested. The examiner proptoses the globe by using atraumatic forceps and then holds the limbus and sees if the globe can be rotated passively farther than what the patient can do by himself. So that is the routine FDT. Here in DRS, we use FDT to assess the tightness of lateral rectus as well as medial rectus. In DRS, this force duction test in the opposite gaze helps to give an idea about the anomalous innervation as well as mechanical restriction forces. So I'll state an example. Suppose there is an ESO-DRS in the left eye, type 1. FDT on the affected left lateral rectus would be free. FDT negative on attempted abduction. Okay, because there is no LR innervation. On the other hand, when you do this on adduction, this will be paradoxically positive because on adduction, the LR gets the anomalous innervation. Now, this resistance gets relieved when the patient is asked to abduct the eye because the globe is now not getting any innervation in abduction. So relief of restriction is due to absent LR firing in left gaze. Force generation test, here the patient is instructed to look maximally in the field of action of the suspected muscle, and here the surgeon grasps the eye in the opposite limbus, pulls against it to evaluate the muscle force, or more appropriately the encountered resistance. Now, this is one specific test which is described specifically for DRS, Romero-Apis force degeneration test. We do not do it in every case. This has to be done whenever you want to differentiate. There is some clarity regarding the differentials is required. So here, the patient is asked to look halfway between the primary position and full adduction. Now the examiner holds the temporal limbus and he further attempts to push the eye more into adduction. Patient is also asked to adduct the eye. At this moment, there is a resistance which is encountered because of the co-contracting lateral rectus muscle. Now from the same position, the patient is asked to abduct the eye. So this is how it goes. So in the first image, you see that the patient is made to fixate between primary position and full adduction. Second step, the examiner is pushing the eye into adduction. And from that adducted position, now the patient is instructed to further abduct the eye. So what is happening here? Initially, there is a resistance in adduction felt because of the co-contracting lateral rectus muscle. In step 3, as the patient attempts the abduction, the previously present resistance now disappears because the LR innervation is nil now. So that is Romero-Apis force degeneration test. So before you take up the patient for a surgery, 5 questions need to be answered. What is the degree and quality of LR co-contraction? So this you will get to know by a thorough observation and grading of the overshoots and globe retraction. Question 2, is there any degree of LR recruitment on abduction? Is there any residual LR activity? Here you go for observation plus active FGT. Now, what is the MR type? What is the contribution given by MR contracture? Go for an FDT. Now, what is the cause for adduction limitation? Is it due to tight LR? FDT tells you the answer. Is it an underacting MR? FGT gives you the answer. And if there is a co-contraction present or not, force degeneration test will help you. And is there any secondary change in vertical muscles? This will be evident if there is a hypertrophy in primary gaze position. Most often it is the superior rectus muscle which will have a secondary change. So diagnostic factors necessary to manage DRS patients include pattern recognition, primary position deviation, presence of fusion, severity of dominant features, presence of any residual LR innervation, secondary muscle changes and fixation if present or not with the DRS eye. Cycloplegic refraction to be reserved to the end of your examination. Thank you very much. Now, Fatima madam will be dealing with the management of DRS cases. Over to you, madam.
Thank you, Samyukta, for your very lucid presentation.
Very good evening. Earlier, speakers have covered the important aspects of DRS. Now, let us see the management aspect. So already mentioned the importance of refraction even in DRS. Even DRS you can have accommodative esotropia. So it is better to have in mind. And when to plan surgery, better to avoid less than 5 to 6 years. Till then you can tell the parent to maintain, allow the child to maintain face turn because let the binocular vision be maintained so that sometimes some mother will be more anxious and correct and the child will start suppressing one eye. So when to plan intervention, whenever there is significant strabismus in primary position or significant AHP or significant globe retraction or upshoot or downshoot. This is the classic ESO-DRS described in Rosenbaum where there is equal to type 1 actually, no normal LR recruitment, only anomalous LR in up gaze or down gaze. So, here, like only here and here. So it gives a typical pattern kind of this way. So here abduction limitation is this much, but up gaze and down gaze the limitation is less. So this kind of pattern is seen only in DRS, not in LR palsy. In LR palsy, as already mentioned, the esotropia is proportionate to the amount of limitation, whereas in DRS the esotropia is very less considering the proportion of the abduction limitation. So whenever we do a medial rectus recession, we should keep in mind the amount of co-contraction of the lateral rectus because it influences in significant way. If it is mild, only 4 to 5 millimeter recession will correct only 10 prism ESO, whereas if it is moderate, it will correct 20% ESO, because your lateral rectus is acting against adduction. It is also pulling the eye outside. If there is severe LR co-contraction and you are doing the same amount of recession in a medial rectus, even the eye can go to abduction, to exo position. It is called a split, induced split. So that is a very important aspect we have to remember when we touch the medial rectus of the Duane's eye. So in case of esotropic DRS, first thing we have to, as already mentioned, clearly explained by Dr. Samyukta, we have to look for how much is the LR co-contraction, whether it is small, moderate or marked. How to diagnose anomalous LR activity, already discussed, whether how much is the globe retraction and upshoot or downshoot. Either it would be in the form of globe retraction or its equivalents. Equivalents are these upshoot, downshoot, or deficient adduction in opposite gaze, and DRS with split in extreme gaze. When the eye tries to adduct, the eye goes for abduction. So these are all the things already discussed. So again, forced adduction tests are also clearly described. Yeah, Romero Apis test, very good innovative technique to diagnose DRS. And this is based on Burton-Kushner's advice, like for small, for esotropia with a small angle and a small lateral rectus co-contraction, we can go ahead with medial rectus recession, ipsilateral medial rectus recession. Whereas if the angle is large, definitely you have to look for this esotropia in opposite gaze. Already discussed this point. No, esotropia in opposite gaze will tell you how much the LR is working against MR. In the primary gaze, esotropia is more than 20 prism, okay. In adduction also, it should be some amount of esotropia should be there, at least more than 10 prism diopter. If it is less, you can understand, okay, in adduction, your lateral rectus is anomalously working, there is anomalous contraction of lateral rectus, so you can restrict the dosage. So if it is more than 10 prism diopter, you can go ahead with medial rectus recession up to 6 to 7 mm, but not in case if it is less than 10 prism diopter. If it is less than 10 prism diopter, better reserve very less recession for that ipsilateral eye and go with contralateral higher amount of recession. That is called asymmetric recession. This is a boy with 20-degree phase turn and 30 prism diopter ESO. He underwent, because of the less amount of phase turn and less amount of ESO, he underwent single ipsilateral 6 mm recession. There is not much co-contraction. You don't find that much co-contraction. But even then, you can find some minimal 5-degree phase turn is remaining. So it is always asymmetric bilateral recession is more recommended than ipsilateral medial rectus recession. But in small angle, it is difficult to explain to the parents to touch the normal eye. For small angle with very less insignificant co-contraction, we can go ahead with ipsilateral MR recession. What is the mechanism? What is happening when we do asymmetric medial rectus recession bilaterally? This is the non-DSI, fixing eye. So we are doing more recession in the non-DSI. So due to fixation duress, more innervation to medial rectus is needed for fixation. And this inhibits the lateral rectus. What is the advantage of that? The lateral, it's due to Herring's law, this medial rectus innervation comes down. So so it helps to prevent contraction of the Duane's medial rectus, and there also you need not worry about more innervation to lateral rectus and eye going for exo, because this lateral rectus is already not working. So the benefit of this surgery is you get additional effect to prevent contraction of the medial rectus of Duane's eye. So what to do if the lateral rectus co-contraction is moderate? Then you can go for, you need to do, if you want to correct ESO more, you can go for 3 muscle surgery, bilateral medial rectus as well as ipsilateral lateral rectus recession. And also you can go for superior rectus transposition to lateral rectus. This is the one published by Dr. David Hunter, where he gives very good result. He advises medial rectus recession under adjustable, so that if at all some unexpected exo happens, we can adjust in medial rectus, because always it is in DRS there is always a risk of getting exo after ESO surgery. So the way how it is done, the superior rectus transposition after medial rectus recession, superior rectus is okay. This is the recession part. I will go to this. Yeah, superior rectus is secured. Then along the spiral of Tillot's, it is embedded near lateral rectus. If the co-contraction is marked, then we have to remember, we have to do something for the co-contraction. Either we have to do Y split, or you remove the effect of the lateral rectus by doing periosteal fixation. After doing that, you can combine with either transposition of partial vertical rectus or full superior rectus tendon to the lateral rectus to aid abduction. This is we already seen. So Y split surgery we will see. So it's a very good rewarding surgery. What this FDT being is done, and yeah, lateral rectus should be separated nicely from the check ligaments, intermuscular septum. After securing as usual, then we are going to split the muscle in the center, and it will go up around up to 10-15 millimeter. You can use cyclodialysis spatula also to separate the muscle fibers. Yeah, as far as possible, you will separate the fibers, then you will disinsert the muscle from the insertion. Yeah. In the recession, we have to measure the recession from the, first we are measuring the, how much we are going to separate the limbs, then we will measure the recession amount from that point, so that the limbs will be placed 20 millimeter apart. That will give a very good effect. Some books they say 10 millimeter apart, but it's better to go for 20 millimeter, or sometimes it would be very difficult to reach 20 millimeter. At least as far as possible, it should be symmetrically displaced. Yeah, other variants are there. These are also discussed. In case of a synergistic abduction, no other way. We have to deactivate lateral rectus by periosteal fixation. Then we can transpose. This is a Y split pre-operative picture, and Y split done in one eye, DRS eye, and had given good result of disappearance of upshoot and downshoot, and the face turn has also improved. And coming to exo-DRS will invariably will be associated with lateral rectus co-contraction, because the eye is in exo, LR is working. So orthotropic to less than 20 prism diopter exotropia, we can go for here we can definitely go for Y split and recession of the ipsilateral muscle alone. If the exotropia is more than 20 prism diopter, we can go for bilateral lateral rectus recession with Y split of the Duane's eye. Otherwise, even here we can go for periosteal fixation and vertical muscle transposition to improve abduction. This is a patient of exotropia where the unilateral lateral rectus recession as well as Y split was done, and the patient maintained a good alignment. So this is the again for lateral rectus in contralateral eye, like how we mentioned medial rectus in the other eye. The same way, more than 20 prism diopter exo, we can go for other eye lateral rectus. Then how it works, the same way. But the important prerequisite is the good eye should be the fixing eye. If in rare occasion, the Duane's eye may be the fixing eye. In that situation, it's better not to, let me come to that in the further slide. So here we are weakening the normal eye's lateral rectus. What way it affects? It creates a fixation duress, so more innervation to act against normal MR in the primary position. This will, according to Herring's law, this will induce more innervation to the medial rectus also. And from this Harrington's law, this lateral rectus will be inhibited. So it prevents lateral rectus contracture and recurrence of XT. So this is the pre-op exotropia. Because the XT is large, here bilateral LR recession along with Duane's eye Y split was done. So this is the periosteal fixation steps where we will, like that of normal lateral rectus weakening procedure, we will disinsert the lateral rectus and then separate periosteum and fix it in the periosteum with a non-absorbable suture. This video is not that clear. We will fix it with the non-absorbable suture to the periosteum, and we will be carefully closing the fascias and tissues over the, so that the lateral rectus will not come into contact with the globe again. So with this Y or lambda pattern, again it's like a pseudo Brown's. Here to differentiate from inferior oblique overaction, one has to look for minimal abduction limitation in the primary gaze and look for other findings of inferior oblique overaction. Always surgical confirmation is whenever you operate on Duane's eye, the important difference is the lateral rectus, both the muscles will be very tight. The lateral rectus also will be very tight. When you cut the muscle, the eyeball will become soft. Because all the while it was, the eyeball was caught in between the tight muscles. No, when it was released, the eyeball will become little soft. That is a normal sign. And surgical confirmation, beneath the tight lateral rectus, the sclera will be blue. So these are all the confirmative signs of Duane's eye. So to correct the lambda pattern, LR recession with upper transposition can be done. Instead, bilateral superior rectus recession can also be done. In the textbook it is given, we don't have experience. And fixation with DSI, we should be very careful. Sometimes the Duane's eye would be used for fixation. In that occasion, if we operate on the Duane's eye, due to fixation duress against already existing restriction, there will be unexpected outcome in the other normal eye. Usually what will happen when the eye fixates with the DSI, the fellow non-fixing eye will fall or rise in its outward rotation. It will not be like upshoot or downshoot, but it will behave. Behave in a more bizarre way, where the normal eye will fall or rise. But the Duane's eye, because the Duane's eye is good eye, it is fixing against restriction. Here maybe we can try improving the amblyopia in the good eye and improve the fixation, then go for any intervention, or we have to remove the lateral rectus power, like go for lateral rectus deactivation procedure and then decide. Bilateral DRS with fusion. Sometimes the patients will have nice fusion in the primary gaze, or with little face turn they will have fusion and bilateral DRS. It's best to avoid surgery. And maybe a small face turn can be corrected with prism. As rightly said, the lesser the surgical indication, the greater the likelihood of post-operative complications. So because it is bilateral DRS, we need not operate if the patient is maintaining BSV with little acceptable anomalous head posture. But without fusion, we can try surgery. If it is bilateral ESO DRS, we can go for bilateral medial rectus recession, and EXO same LR recession with Y split. For ESO, after recession, depending upon other co-contraction, you can already discussed, you can go for transposition procedure. This is a bilateral bilateral DRS patient where there was cosmetically disfiguring upshoot and downshoot were there. So we went ahead, and a large exo was also there. So we went ahead for bilateral lateral rectus recession with Y splitting. So after surgery, anyway, we have to explain the patient, we are not going to expect any improvement in abduction, rather the only we are going to expect the upshoot and downshoot disappearance. So to summarize, establishing the type of Duane's and individual role of lateral rectus and medial rectus, its innervation is very important, and also we have to look for the secondary muscle change. As already discussed, the main important thing is whether the lateral rectus works normally and whether the lateral rectus works abnormally, whether it co-contracts, and whether the medial rectus has gone for secondary muscle changes. These are all the important deciding factor to decide the dosage of surgery. And address the indication of surgery, patient counseling regarding residual deficits, and plan the type of surgery depending upon the type of presentation. Thank you very much.